For those who don't know me, my name's Sam. I'm one of the PGY2s, and this is my Small Talks lecture. Thanks to the Small Talks team for all the feedback, and nice to see all our PEM colleagues in the building. Okay, we'll start with a case. The chief complaint is a mother weeping uncontrollably. The HPI you can read for yourself. It's a 3-month-old male brought in for cyanosis, was breathing funny, went limp, turned blue, went back to baseline in 30 seconds, born full term, spontaneous vaginal delivery, no complications, no medical history, and they look great. Everything's fine. What does this seem like? What topic am I doing today? Just someone shouted out. BRUE, I don't know how you pronounce it. BRUE. I say BRUE. So brief, resolved, unexplained event, formerly ALTI, apparent life-threatening event. A BRUE has occurred if the following criteria are met. So sudden, brief, and now resolved, unexplained episode of cyanosis, pallor, absent, decreased, or regular breathing, if they have a change in tone, or altered level of responsiveness. This is the low-risk criteria. It's important to know. It's on MD Calc, but you're either low risk or you're high risk as far as the guidelines are concerned. You can read this for yourself. I'm sure everyone's seen this at least once in the past. Really, the last 2 bullets are the scary ones. No concerning historical features and no concerning physical exam findings, because what does that mean? That means you have to dig, and you have to convince yourself that there's nothing concerning with your subjective judgment. So what would you ask this mom, this dad, once they stopped crying? Raise hands, shout out. What types of things in the history might be important? Yeah, exactly. Birth history, that's good. Any other ideas? Yeah, that's super important because that can often be feeding problems can often be a mimic for this sort of thing. So definitely important to ask. Anyone else? One more? Yes. How long exactly? It's probably, I would think that parents would be poor historians on this, because if your baby's not breathing for 10 seconds, it probably feels like an eternity, but you got to ask. There was another one. I'm sorry. Yeah, exactly. What was happening at the time? Here are some things that I've just put down. Any, genetic testing they've done, any, family history of seizures, history of sudden cardiac death, SIDS. Really important to always ask about the social situation, like where are they living, who's in the household, any concerns for NAT, and just generally assessing whether or not the child's, the parents feel like they are adequately caring for the child. Also exposures, smoking, things like that. So what would you do? This is often very variable, but does anybody have 1 or 2 suggestions of what might be reasonable in any child? Actions, tests. I'm just going to go through it. Really, the most common one is just a brief observation. You can just stick them on the pulse ox for a couple hours and just watch them. An ECG is sometimes done, depending on the provider. It doesn't usually show anything. Pertussis PCR is not ubiquitously done, but the idea of checking for pertussis is that it can mimic BRUE by causing choking or gagging even before you get like other respiratory symptoms or fevers or anything like that. But really, the most important thing is just shared decision making. And if they are low risk and you do feel like this baby can be discharged, you just have to make sure they have really close follow up with their pediatrician. So quickly going through a couple more cases. So what's the dispo here? We still have a mother weeping. 30-day-old female brought in by ambulance for cyanosis. They say she was limp for a few minutes. What is this? Is this dischargeable? What do we think? Shout it out. Discharge? Admit? I agree. Admit, probably, right? Because it's a 30-day-old. So the cutoff is 60 days. Definitionally anything that's not low risk is high risk. So this kiddo is too young and probably would need to be considered for admission, although, you know, all of this is a little bit fungible. Case number 3, there's a 4-month-old coming in, same basic story, and then on exam, you just hear some scattered wheezing and some nasal flaring. So I'll just ask, is this a BRUE with the same basic story? No, right? Because they're not at their baseline. They're wheezing. So you would work up the wheezing. Quick shout out to MD Calc. They have a checklist, as they have everything, all checklists. But if you ever get confused on these guidelines, you just look it up. Case 4, what's the dispo? You have a 61-day-old female coming in for cyanosis at home. They started breathing funny, went limp, and turned blue. It's the same basic story, back to baseline in 30 to 60 seconds, maybe. Seemed a little fussy lately, but nothing major that you can really get on the history. No obvious pertinent positives. You ask about home situation, family situation. The question of what's the dispo, really, there's no right answer, which is what makes this chief complaint so difficult. The clinical guidelines rely so heavily on, you know, your subjective judgment, your history, your physical exam. So your workup, your disposition should really be tailored individually to each patient and should really involve the parents. It'll also be influenced by just your level of experience and your personal style and approach. So just a couple of very brief jaunts through a couple of papers. There is evidence that the guidelines changed from ALTI to BRUE in 2016, and now there's some evidence that's suggesting that the guidelines, in a certain sense, are seeming to work. When considering the low risk group, at least, there was a paper in 2019 that showed that using the criteria in discharging low risk kids did not result in more bounce backs, essentially, which is just showing that we may be, you know, discharging these kids appropriately. And it showed a significant decrease in like unnecessary testing and admissions. So we're basically saving kids and parents admissions without any clear signal that we're doing harm by sending low risk kids home. On the other hand, when you look at the other end of the coin, for the high risk group that gets admitted, it's rare that you actually find a reason for what happened. There was a paper in Academic Emergency Medicine that basically showed less than half of kids who get admitted get even any sort of explanatory diagnosis. But when you actually dig into that diagnosis, it's supported by like a test or an image or, you know, any piece of hard data, almost never. So I sort of almost think of this as like admitting like syncope, where it's like, sometimes you usually just have to, but you got to stick them on telly for 24 hours and you're probably not going to find anything and they're probably going to go home and no one's going to know what's up. This is the same idea.